Hiccups, medically known as singultus, are involuntary, intermittent contractions of the diaphragm and intercostal muscles, immediately followed by a sudden closure of the glottis. While most hiccups are benign and self-limiting, persistent or intractable cases can signal serious underlying diseases and necessitate targeted medical intervention. Clinically, hiccups are classified based on their duration. Acute hiccups last less than 48 hours, persistent hiccups extend beyond 48 hours, and intractable hiccups persist for more than 1 month, often indicating a more complex underlying issue. Hiccups occur due to the activation of a specific reflex arc involving several key neurological components. This reflex arc consists of an afferent limb, which includes the vagus nerve, phrenic nerve, and sympathetic chain, transmitting signals to the central processing unit located in the medulla and brainstem. From there, an efferent limb, primarily the phrenic nerve, sends signals back to the diaphragm, causing its characteristic spasmodic contractions. Any irritation or disruption along this intricate pathway can trigger the hiccup reflex. Common causes of hiccups are diverse and can be broadly categorized. Gastrointestinal issues are among the most frequent culprits, including conditions like gastric distension, gastroesophageal reflux disease or GERD, peptic ulcer disease, esophagitis, hiatal hernia, subphrenic abscess, and pancreatitis. Notably, GERD is a particularly common cause of persistent hiccups. Beyond the digestive system, central nervous system problems can also induce hiccups, such as strokes, especially those affecting the brainstem, multiple sclerosis, brain tumors, meningitis or encephalitis, and traumatic brain injury. New-onset persistent hiccups, accompanied by neurological signs, should always raise suspicion for underlying CNS pathology. Metabolic and systemic causes include uremia, electrolyte disturbances like hyponatremia or hypocalcemia, hypoglycemia, and alcohol intoxication. Thoracic and cardiovascular causes encompass pneumonia, pulmonary embolism, mediastinal tumors, pericarditis, and myocardial infarction. Lastly, certain medications can induce hiccups, such as corticosteroids, benzodiazepines, chemotherapy agents like cisplatin, opioids, and dopamine agonists. Acute hiccups often respond to simple non-pharmacological measures aimed at interrupting the reflex arc, such as breath holding, performing the Valsalva maneuver, drinking cold water, or swallowing granulated sugar. For persistent cases, pharmacological management becomes necessary. Chlorpromazine, administered at 25 to 50 milligrams orally or intravenously, is the only FDA-approved drug specifically for hiccups. It acts as a dopamine antagonist, though clinicians must be mindful of potential side effects like hypotension, sedation, and extrapyramidal symptoms. Other effective medications include metoclopramide, typically 10 milligrams orally or intravenously, which is particularly useful for GERD-related hiccups due to its dopamine antagonist and prokinetic effects. Baclofen, a GABA-B agonist given at 5 to 10 milligrams 3 times daily, is effective in hiccups with neurological origins, though sedation and dizziness should be monitored. Gabapentin, at 300 to 900 milligrams per day, modulates calcium channels and reduces neuronal excitability, proving effective in intractable hiccups, especially those associated with cancer or central nervous system disease, and is generally well tolerated. Less common pharmacological options include haloperidol, amitriptyline, and nifedipine. Crucially, effective management of persistent hiccups always involves treating the underlying cause. This could mean prescribing proton pump inhibitors for GERD, initiating dialysis for uremia, correcting electrolyte imbalances, administering antibiotics for infections, or withdrawing any offending drugs that may be inducing the hiccups. In severe intractable cases unresponsive to medical therapy, surgical and interventional options may be considered as a last resort. These include phrenic nerve block or ablation, which involves chemical or surgical interruption of the nerve, though it carries the risk of diaphragmatic paralysis. Vagus nerve stimulation is a rare option used in refractory neurological hiccups, and surgical correction may be performed for structural causes such as tumors or hiatal hernias. In summary, while most hiccups are benign and self-limiting, persistent hiccups are not trivial and necessitate a thorough evaluation for serious underlying diseases. Chlorpromazine remains the primary FDA-approved pharmacological treatment, but it is paramount to always identify and treat the underlying etiology, whether it be gastrointestinal, neurological, metabolic, or drug-induced. Surgical options are reserved only for the most refractory cases. Persistent hiccups can indeed be the first sign of a significant medical condition, underscoring the importance of comprehensive assessment and appropriate management.